Thank you, Steve. It's certainly nice to be here. I'm obviously biased because I did a PhD in Lp(a) research, so I was always convinced about the importance of this lipoprotein. But it is good to see that overall research and interest in Lp(a) is thriving again. I was part of the organizing committee of a satellite to the EAS earlier this year in Innsbruck, where we purely talked about Lp(a) for 2 days. And initially we expected between 50 and 75 participants at this meeting. We're very pleased to see that there was over 200, and some of you in the audience were there. It was really a very interesting meeting with excellent discussion. So let's jump straight into the talk. Lp(a), as Steve already alluded to, is a very atherogenic lipoprotein. It consists of an LDL particle, one ApoB100, and a small glycoprotein that's linked to this particle via disulfide bridge. So it basically bridges atherosclerosis and thrombosis. It has all the negative effects that LDL has, but it also interferes with fibrinolysis, as I'll show you, based on this apolipoprotein small a that is a glycoprotein, as I mentioned before. Now, initially, when we did studies many years ago in Austria, we established a threshold of 30 milligrams per deciliter in normal individuals, which is still taken by many, many investigators as the level above which Lp(a) is atherogenic. This has recently moved to 50 milligrams per deciliter in the EAS guidelines, and in some European countries where LDL apheresis is available, we talk about additional therapy, as I'll show you, above 60 milligrams per deciliter. But we'll get into that during my talk. Now, Lp(a) is a causal factor in atherogenesis. There's certainly no doubt about that. And the strongest indication comes from epigenetic meta-analysis, Mendelian randomization studies, which are very topical with LDL at the moment as well, and genome-wide association. All of those have basically shown that increased levels of Lp(a) are associated with an increased risk of cardiovascular disease. Now, Lp(a) is especially a risk factor if other risk factors are present. So this is data from our Vienna heart study many years ago, where we could show that if you have diabetes or high blood pressure, if you're a smoker, if you have elevated homocysteine or other risk factors, the addition of elevated Lp(a) increases the odds ratio of cardiovascular disease quite dramatically. Lp(a) is one of these lipid risk factors that is responsible for residual risk. And what you can see on this slide from AIM-HIGH, the lipid trial and the Jupiter trial, if your Lp(a) is elevated in patients who achieve a very low LDL cholesterol in primary and secondary prevention in these trials, your risk of cardiovascular disease is significantly elevated compared to lower levels of Lp(a). So it's certainly one of these factors that's responsible for residual risk, as is low HDL and elevated triglycerides, of course. The other interesting thing about Lp(a) comes again from genetic studies that show that there is an association between valvular calcification, especially aortic stenosis, and Lp(a). So the gene locus for Lp(a) has been shown to be significant for aortic valve calcification. And this has been extended to other valves in very small studies recently. So how is Lp(a) atherogenic? Well, as I mentioned before, it contains an LDL particle, and everything bad that can be said about LDL can also be said about Lp(a). In addition to that, it interferes with fibrinolysis. It interferes with plasminogen plasmin binding. It interferes with TPA, and it interferes with integrin receptors as well. In addition to that, Lp(a) can be oxidized, similar to LDL, and it acts as a sink for oxidized lipids. So all of these and a couple more parameters explain why Lp(a) is such an atherogenic lipoprotein. This is data from the Copenhagen General Population Study. Sorry, I'll just go back one. Where Langstedt and colleagues looked at familial hypercholesterolemia in this population, but also looked at Lp(a) levels. So they basically looked at clinical FH and divided their population in several groups above and below 50 milligrams per deciliter in people with and without FH. And what they basically found is summarized here. They not only found that there's a 52% increase in lipoprotein A levels in clinical familial hypercholesterolemia, but this also seemed to explain part of familial hypercholesterolemia. So the lipoprotein A cholesterol in this cohort seemed to account for up to 1/4 of FH patients. So we know now that patients with elevated lipoprotein A account for a certain percentage of FH population. Now, when should we as clinicians measure Lp(a)? The thing that really has changed is vascular imaging. If you have an intermediate risk patient nowadays, you probably have a low threshold to look at calcium scores, to look at carotid intima media thickness, but I think that Lp(a) is still a very good intermediate risk marker. So we recommend to measure Lp(a) in people with premature cardiovascular disease or stroke, because this will explain some of their risk, especially in intermediate cardiovascular risk patients if it changes your treatment algorithm. And the third group is in patients who have rapid progressive vascular disease. In these patients, obviously, LDL needs to be treated more aggressively anyway. And then, because it accounts for familial hypercholesterolemia in FH patients, the presence of elevated Lp(a) levels also tells you that these patients need to be treated more aggressively from an early age, similar to an early family history for cardiovascular disease. Now, how can we treat elevated Lp(a) levels? The most important thing, and we've said that for years, is to really aggressively lower LDL cholesterol in people with hyper-Lp(a) to levels of less than 1.5 millimole per liter in the case of very high-risk patients. ACE inhibitors reduce Lp(a) in proteinuric patients. We have shown this first for fosinopril, but other ACE inhibitors basically do exactly the same thing. Nicotinic acid lowers Lp(a), and we've described the mechanism a couple of years ago. LDL apheresis is obviously something that's available in specialist centers, but also very effective at reducing Lp(a), very expensive though. And then there are some new therapies like antisense and other novel lipid-lowering therapies that affect Lp(a) significantly. Now, what about currently available drugs? So statins are not very good drugs to lower Lp(a). There's inconsistent data. In some cases, they even increase Lp(a). And the interesting thing about that is that it shows that the LDL receptor is not responsible for Lp(a) clearance in most instances. Nicotinic acid we've talked about. Aspirin has a small Lp(a) reduction, but certainly can't be used solely for this purpose. L-carnitine has been shown to reduce Lp(a) to a small degree. Fibrates reduce Lp(a) in some studies, but not all studies. And LDL and Lp(a) apheresis we are going to talk about a little bit in the coming slides. Hormones influence plasma Lp(a) levels, growth hormone, for example, but also estrogens, progesterone, and tamoxifen have shown to reduce Lp(a) significantly. Tibolone, for example, is another one. And testosterone, we first saw that in bodybuilders, also reduces Lp(a) significantly, but obviously can't be used for this purpose clinically. Now, tranexamic acid is an interesting compound. It's used for people who have excessive bleeding, especially with prostate surgery, etc. Also has an effect on Lp(a). We could show that first in transgenic mice, but later could repeat that also in humans. But again, something that unfortunately can't be used in the wider population clinically. Niacin reduces Lp(a), especially in the higher doses, by up to 30%. I've already mentioned that. And we looked at the mechanism a couple of years ago and found that ApoA expression in human primary hepatocytes is significantly reduced with nicotinic acid. The problem with niacin is that it's clinically not available in Australia to a large degree anymore, especially since large trials have shown that if you add niacin to statins, the outcome is not going to be much better than if you use a statin alone. So certainly not a therapy that's used widely at the moment, even though I think there is still a role for niacin in selected populations, such as populations with elevated Lp(a). What about LDL apheresis? 15 years ago, we could show that LDL apheresis not only reduces LDL significantly, obviously, but also leads to an 60 to 80% reduction in Lp(a) in heterozygote FH patients. And we saw that coronary calcium scores and plaque on CT angiography were significantly reduced if you did that for 3 years in combination with statin therapy. Certainly a very effective therapy, but the clinical data initially was scarce, especially with regards to larger cohorts and outcome trials. Now, this was a publication from Germany. It was an observational multi-center study that looked at many centers that did LDL apheresis in Germany and found a significant reduction in MACE 1 year and after initiating LDL apheresis. This is something that is very topical at the moment because there are several studies looking at this, and LDL apheresis seems to be very effective at reducing events in people with elevated Lp(a) and progressive coronary disease. And this shows you the start of LDL apheresis in this large multi-center observational study. There was an almost 80% reduction in adverse events with LDL apheresis. What's missing is obviously a multi-center randomized controlled trial, and this trial is underway at the moment to look whether LDL apheresis really reduces events in a larger cohort, and then a meta-analysis, obviously. But LDL apheresis certainly looks very promising. What about other drugs to reduce Lp(a)? And David Hare is going to talk about this afternoon, but I thought I'd give you a little bit of an introduction to this already. Mipomersen is a drug that's not available in Australia, but in other countries around the world. It's an antisense therapy. It's a weekly injection, unfortunately a lot of side effects, but it does reduce Lp(a) by up to 40%. The mechanism is not quite clear, but is currently being investigated. Mipomersen is really a drug for homozygote familial hypercholesterolemia. It's not going to be available for Lp(a) or the wider population. There is no doubt in our mind about that. What about CETP inhibition? Anacetrapib is one of the few CETP inhibitors that's still in outcome trials. All others, unfortunately, haven't shown much benefit, but it certainly also has an effect on Lp(a). So if you look at the reduction with anacetrapib, for example, you can see an up to 40% reduction in Lp(a). Again, the mechanism is not entirely clear, but it certainly is a drug that's effective for Lp(a). And Steve will tell us later, I think, about outcome trial with anacetrapib. And if this is positive, we will not know whether this is due to increasing HDL or decreasing Lp(a), LDL, and other lipid fractions. Now, what about PCSK9 inhibitors? This is also very topical at the moment. You all know what PCSK9 inhibitors are. There is a session on PCSK9 inhibitors. Not going to talk too much about it, but there's basically 3 in clinical trials, 2 already registered in Australia, evolocumab and alirocumab. These are monoclonal antibodies, but there is obviously a lot of other approaches how you can inhibit PCSK9 with vaccine-type approaches, with small molecules, and mimetic peptides. But this is certainly not the topic of my talk today. The interesting thing about PCSK9 is that the loss-of-function mutation that most of you are aware of not only shows reduced LDL cholesterol levels, but also shows reduced lipoprotein A levels. So if you look at patients who have PCSK9 in loss-of-function mutation, R46L, and if you compare non-carriers and carriers, you can see that not only myocardial infarction is reduced in the non-carriers, but also aortic stenosis is less common, which fits very, very well with the data that I showed you initially from genetic studies that shows that Lp(a) is involved in calcification of the aortic valve. PCSK9 inhibitors significantly reduce Lp(a). This is a pooled analysis with evolocumab in 1,300 patients in 4 phase 2 trials, and as you can see, the Lp(a) reductions are up to 30%. The same can be shown with other PCSK9 inhibitors, and in this case, alirocumab, for example, also you get an Lp(a) reduction of up to 25%. Now, one of the interesting things is that it is not clear entirely how PCSK9 inhibitors do this, because, as I said initially, the LDL receptor doesn't play a big role in clearance of Lp(a), even though there's some small studies now that would implement that there is a small role. So Gilles Lambert presented a very interesting paper in Innsbruck where he could basically show in dermal fibroblasts that unlike LDL uptake, Lp(a) uptake is not altered by PCSK9 inhibitor alirocumab. And unlike LDL uptake, Lp(a) uptake is occurring in the absence of a functional LDL receptor. When he looked in primary hepatocytes, he found something similar. Unlike LDL, LP-little-A uptake is not altered by PCSK9. And unlike LDL uptake, LP-little-A uptake is not affected by LDL receptor blockade with a monoclonal antibody. So LP-little-A cellular binding and whole particle uptake are not altered by PCSK9. Secretion of ApoA is enhanced by PCSK9, and the effect blunted by alirocumab. Hugh Barrett, who is in the audience together with Gerald Watts' group, has shown at the same meeting that in healthy men with normal plasma lipid and lipoprotein concentrations, including LP-little-A, evolucumab lowers LP-little-A plasma concentration, lowers ApoA production, but does not change the ApoA fractional catabolic rate, despite a 74% increase in LDL ApoB fractional catabolic rate. And the mechanism of action may be related to the reduction in ApoB, which lowers the pool of ApoB available for binding to ApoA, leading to lower plasma concentrations. But I have to say that Henry Ginsberg, Gerald will discuss that probably a little bit, didn't find exactly the same thing. So he found slightly different effects with regards to the fractional catabolic rate. I personally think that the assembly of ApoA and ApoB might be affected by PCSK9 inhibitors, something that we are looking at the moment together with my father's group in Austria. What about other therapies? The probably most promising therapy for isolated elevated LP-little-A is antisense therapy. Similar to what has been shown for mipomersen, which is an ApoB antisense, you can create an antisense strand against ApoA. And this has been shown by a company called ISIS, and this is basically very effective in reducing LP-little-A by up to 82%, even more in some individuals. Not going to bore you with the details of what antisense is. Most of the people in the audience are very familiar with this. It's basically creating an ApoA RNA antistrand and preventing a protein from being formed. And if you do that for ApoA, you get reductions of ApoA, obviously. This is the reduction not only in LP-little-A, but also oxidized phospholipid following ApoA antisense therapy. This is very promising, as you can see on this slide. And LP-little-A oxidized phospholipid reduction also reduces monocyte activation in patients with elevated LP-little-A. And as I said, more than 80% LP-little-A reduction you get using this 1 to 2 monthly injection with this antisense therapy, and this is obviously being investigated in phase 2 and 3 trials at the moment. What about other approaches? Many years ago, I saw that there is an inverse relationship between bile acids and LP-little-A levels. So if you look at people before and after cholecystectomy, for example, we found that total bile acids obviously go down after you remove the gallbladder, but LP-little-A levels seem to significantly increase. And based on that, we postulated that bile acids must play a role in LP-little-A metabolism. And we looked at that. We fed ApoA transgenic mice with cholic acid and found significant changes in plasma LP-little-A levels, as you can see on this slide. And we also found that liver ApoA messenger RNA levels were significantly altered by this approach. And this is obviously something that can be done to a certain degree in humans, even though bile acids at higher concentrations have significant side effects, as many of you know. But this is certainly interesting because there are certain selective FXR ligands which basically act like bile acids without having the same side effects. So this is something that certainly can be tested in humans. And several companies now have FXR agonists that work very similar to these bile acids without having the same side effects and can probably be used to lower LP-little-A levels in humans. So, Mr. Chairman, ladies and gentlemen, I know that this was a bit quick, but it's always good to make a bit of time at the beginning of a meeting. The take-home messages from my talk are that LP-little-A is a risk factor for vascular disease. This is genetically determined. It's an independent risk factor and very likely causal. Measurement is indicated in patients with intermediate risk, early onset cardiovascular disease or unexplained cardiovascular disease by conventional risk factors and their first-degree relatives, and patients with recurrent or rapidly progressive cardiovascular disease. And this is the group of patients where LDL apheresis, for example, is reimbursed in Germany and other countries around the world. Therapy initially should certainly be an aggressive LDL reduction with statins and ezetrol if you don't achieve your goal. Current drug therapies such as niacin are modestly effective, not always available. Apheresis is effective in those centers that have apheresis, and there's very few in Australia. It's just Richard O'Brien, Gerald Watts, and I think one other center, probably in Sydney, that has LDL apheresis at the moment. And future therapies are very promising and include PCSK9 inhibitors and Lp(a) antisense therapies. But we have to keep in mind that these therapies are very expensive. And to purely lower Lp(a) levels, we need more data that this is really sort of going to add additional benefit on top of the benefit that you see with LDL lowering in these patients. And last but not least, a small algorithm that you could use. Lp(a) is elevated above 30 or 50 milligrams per deciliter, depending which cutoffs you want to use. Patients without atherosclerosis, you're obviously going to optimize all other risk factors, especially LDL. But patients with significant atherosclerosis, after optimizing all risk factors, lowering LDL to low levels, in those patients where progression of atherosclerosis is present, apheresis or PCSK9 inhibitor could be considered if Lp(a) is above 50, 60 milligrams per deciliter, provided this is reimbursed, obviously. And for those of you who are interested in lipids, we have the World Congress of Clinical Lipidology coming to Brisbane in February. So I'd like to invite you all to participate in this. You'll obviously hear much more about this and other topics. And with that, Mr. Chairman and ladies and gentlemen, thank you for your attention.